Got it up. Thank you for joining us. Happy Tuesday. Mahalo, Dr. Chester, for presenting again. We're always happy to have you. And without further ado, I did go ahead and give you sharing capabilities so you can take over.
Thank you. Let me share my screen here and we'll get started. Okay. Oh, I gotta go to the top. Don't look, everyone, don't look. This is a quick view. Okay, here I am. Very professional, I know. So my name is Dr. Jeffrey Chester. I am in solo private practice and have been on Maui full-time for over 2 decades. I have a few board certifications. My latest is a board certification in addiction medicine from the American Board of Preventive Medicine. But I'm also board certified by the American Board of Addiction Medicine and board certified by the American Board of Physical Medicine and Rehabilitation. So my story briefly is moved here. They said we need chronic pain treatment. I started treating chronic pain, soon realized that at least a subset of my patients really had what we now refer to as an opioid use disorder, and started treating that. Fast forward with a few good mentors and a lot of study, board certified in addiction as well as treating chronic pain. So that's what I do here. My email address is there at the bottom. That's my personal and professional email address that goes straight to me in case someone wants to send me an email. There's a picture of me in the lower corner, and that's because my son was helping me make slides and he thought that would be funny. So he did that. So, and there it stays. So we're going to talk about, we're going to talk about, first I'm going to talk and then I'll let people give their input toward the end. But our objectives are to understand that treatment needs to be tailored to the individual, to expand knowledge about substance risks and federal schedules, and to reconsider medication treatment biases that we have to promote harm reduction. So thank you for inviting me. It's really an honor to be invited back to do another talk. Today's topic, is it acceptable in residential treatment centers? Alternatively, I've thought of 4 other ways to title this talk. Is it acceptable in sober living facilities? Is it acceptable in any person in recovery? Is it acceptable in persons with no history of chemical use disorder? And is it acceptable in persons with low risk of chemical use disorder? So what we sometimes forget if we're treating in the addiction field long enough is that there are people that are not with substance use disorders. The origin of this talk's topic was I was covering for an addiction psychiatrist's duties at a residential treatment center in Hawaii. So he went on vacation. I won't say who, doesn't matter, but I was covering, and so I took over. So one of the residents that he had admitted a few days prior, before I took over for about a 2.5-week period, is a person with a history of anoxic brain injury and both central sleep apnea and obstructive sleep apnea. So I'm going to back up a little bit. Anoxic brain injury means lack of oxygen to the brain, causing a problem in the brain. It sometimes is similar to a traumatic brain injury, like a severe concussion or a mild concussion. It also can present with certain long-term problems, such as problems with sleep, and problems with irritability and impulsiveness. So there is some overlap in how anoxic brain injury can linger. It's some similarity to when we see our patients with either addictions or with psychological and psychiatric problems. Sleep apnea, briefly, is while you're sleeping, you have periods of time where you pause your breathing. Central sleep apnea means it's coming from the brain and brain centers. And obstructive sleep apnea means there's something that is blocking the airway, your windpipe. And there's just generally accepted, actually 3 different types, but for this talk, there are 2 main types of sleep apnea. So when you don't sleep well because you have problems getting oxygen overnight, during the day you can be pretty exhausted, pretty fatigued, as well as irritable, and it increases your risk of certain diseases such as high blood pressure and diabetes. So it's a pretty major thing once we find out what it is to treat it. So this patient had this client had this, and he requested his medicine, and the CEO of the center was hesitant to allow this person to continue his sleep apnea medication. In this case, it was called Sunosi, which is a Schedule 4 medicine, for fear of potential misuse, abuse, or addiction. So Schedule 4 generally means a low risk in terms of how they determine the schedule. So briefly, federal schedules go Schedule 1, 2, 3, 4, 5, and also unscheduled drugs, medications. So the bigger the number, generally the lower the risk. That's the intention of the schedules. The same person had been allowed to continue his Suboxone on sublingual tablets, which is a Schedule 3. So a higher risk category if you're looking in terms of the schedules. And that was for his chronic opioid use disorder. So he's on Suboxone, a medicine that, according to the schedules, is a higher risk than the medicine in question. In addition, that same person had been successfully medically managed by the addiction psychiatrist for acute alcohol withdrawals. And they used Librium, which is a Schedule 4. Again, by the schedules, it would be a lower risk than the medicine in question for his sleep apnea. And the reason that they were questioning is because there are some people who misuse, abuse, and become addicted to sleep apnea medicines. The same person also had been on gabapentin, 800 milligrams by mouth 4 times a day for his chronic lower back pain. And when he requested it, I had allowed for him to continue it, but I reduced it down to 3 times per day. One of the reasons was he was stating that his lower back pain was from his job, and since he was in a residential facility, he wasn't going to be doing that job. So I thought I would lower down his dose a little bit and see how it went, assuming he would have less lower back pain. Gabapentin, also used to be called Neurontin. Gabapentin is not scheduled. In other words, it's so low down on the federal level scheduling risk factors that they didn't schedule it. But that's at a federal level. But in certain states, as of November 2022, it was classified as a Schedule 5 medication. So that's a little bit of a step up, and we should watch this a little further. And that's in certain states: Alabama, Kentucky, Michigan, North Dakota, Tennessee, Virginia, and West Virginia. And that's because gabapentin is increasingly implicated in overdose deaths. Oh, let me go back. So to quote this JAMA article, post-mortem, in other words, after people have died and they do testing on them after they've died, toxicology tests have detected gabapentin in almost 1 in 10 US overdose deaths between 2019 and 2020. In about half of, that should be of, not O, half of these cases, a medical examiner or coroner ruled the drug was a cause of the death, according to a report from the CDC's Division of Overdose Prevention. That's from a JAMA article. So it does point to the fact that maybe gabapentin should be taken more seriously, maybe have more restrictions on it, maybe watched more closely. I highlighted CDCs in green on this slide because my autocorrect kept autocorrecting CDC to CVS, if that gives you some idea of what most of my day involves, dealing with pharmacies. Okay, so brief history here about the federal schedules. President Nixon and the war on drugs, part of their strategy in 1970 was this Controlled Substance Act. And that was the origin of our modern day federal classifications of certain substances and how much restriction should be on them and how little restriction should be on them. These are called schedules. So the question is, can one use federal drug schedules to make decisions about individual risks and policies about what medications are not acceptable? And I think what I've tried to demonstrate here is one cannot just use these schedules to make decisions about risks in individual people at any given time. So is medical treatment, such as medical treatment for sleep apnea or anything else, any other medical condition, is it inferior to abstinence for chronic conditions for those with chemical use disorders? And we'll talk about non-chemical use disorders. In other words, is it inferior or superior to be on a medicine? Is it better or worse to be on a medicine and treated for a condition versus not be on a medicine, what we like to call abstinence? Or is it better to be on that medication treatment? So what about those for conditions other than substance use disorders, chemical use disorders? So I gave a few examples here: diabetes, hypertension, hyperlipidemia, which is high cholesterol, epileptic seizure disorder, which is the preferred term for seizures, depression, attention deficit hyperactivity disorder, cardiovascular disease, like heart disease, COPD, which is sort of like asthma, it's a lung disease, or sleep apnea. And I came up with this group because it spans kind of a wide range of what people think of when they think of medical problems. Is it better to be on a diabetes medicine than not? Depends if your diabetes is under control without a medicine or not. High blood pressure and high cholesterol, we know if untreated, are major risk factors, amongst others, like diabetes, for strokes and heart attacks. So we lower people's risks by putting them on medications. Seizures, leaving seizures untreated can be not only problematic for the individual, but people around them, let's say if they are driving a car. Depression, do we treat it with medicines or not? Which is better? Depends on the situation. So I put ADHD in there specifically because I know it comes with some biases that we have about whether we should have someone on certain medicine or not for ADHD. So cardiovascular disease, just as a general description of heart pumping problems or heart circulation problems. COPD, like I mentioned, is like asthma. It's a lung disease. And then sleep apnea that we mentioned before. Do we leave someone at risk for daytime fatigue, high blood pressure, other problems? Do we also risk them having a severe low oxygen level overnight while they're sleeping, while they're in our residential facility to treat their addictions? So, are all medications that help with daytime wakefulness of similar risk for misuse, abuse, or addiction? And here's a list of sleep apnea medications: Provigil, Nuvigil, Modafinil, Sunosi, armodafinil, and solriamfetol. Thanks for getting that out. I guess I don't use that one too much. If we don't treat people, they can have some severe problems, including severe brain injury. And if we do treat them, some of these medicines have been demonstrated in individuals to be a source of abuse, misuse, and addiction. They are all different types of schedules, these medicines. So we can't go by the schedules. And of course, there are a lot of insomnia medications that are prescribed to help people, excuse me, with daytime sleepiness. That's why we treat insomnia. Sometimes with medicine, sometimes without. They all have varied risks for misuse, abuse, and addiction. When I started to think of insomnia medications, the list kept going on and on. So I just had to kind of abbreviate it. So some of them are Zolpidem, which is Ambien, which we know can be a source of it's a sedative hypnotic and can be a source of problems. Same with Lunesta. And then we use sometimes for insomnia medicines like lorazepam, also known as Ativan, Librium that we mentioned before, Valium, also called diazepam, alprazolam, which is Xanax, clonazepam, Sonata, Zalplon, I can't say this. Okay, Razarem. I put in this list here trazodone because we tend to use that in people with chemical use disorders and without, because it generally is a low risk. But it can make people very tired the next day. And I put gabapentin in this list because we use that sometimes for insomnia as well. Sometimes we think it's appropriate, sometimes we don't. Topiramate, also called Topamax, is sometimes used for keeping seizures away. Sometimes it's used for migraine headaches, other types of chronic pains. And sometimes we use it for anxiety treatments in people that we're trying to minimize or avoid benzodiazepines with. So sometimes we use topiramate for that. So they all have very varied risks. Of course, leaving chronic insomnia untreated is very risky as well. That chronic insomnia has been the source of several studies, and it seems that increases your risk of premature death as well as cardiovascular disease, and in the short term can make you tired enough to not drive safely the following day. So other medications that we use for insomnia include the tricyclic antidepressants, TCAs for short. Some of those include medicines called doxepin, amitriptyline, nortriptyline. Again, some people the following day can be so sleepy that they should not be operating heavy equipment, driving a car. Sometimes we use prazosin, especially for people who have nightmares, and sometimes we use clonidine. Again, varied risks, various potential risks with these medicines. And then I want to mention the over-the-counter preparations, which come with their own risks, even though they don't even require a prescription. So I don't know if anyone has ever come across, but I've certainly come across people say, oh, Benadryl, I can't take that. Take that the whole next day. I can barely think straight and get out of bed. I have to take the next day off work. So there are plenty of over-the-counter preparations, both prescription and non-prescription medications, and of course, non-medications. So which are superior and inferior? I guess my point is it depends on the situation. It's all context. So very controversial. So I figured I'd bring it up. What about cannabis for insomnia? And cannabis is a wide range of chemicals. Um, some are high THC level products, and some are very low THC products. Some are primarily CBD preparations. Some of those over the counter ones don't even need a prescription. Some are topical. Um, so I'm just bringing them up so that we can start as individuals to consider what we feel safe giving to people, what we don't feel safe giving to people, and why we've drawn those conclusions. And should there be a hard and fast rule? Should there be protocols? Should there be algorithms to follow? Or should we take this all in context based upon the individual and the setting they're in and the risks that are both in the short term and long term for that individual, as well as the people around them? What about treating a person's ADHD related insomnia with bupropion, atomoxetine, also called Strattera, or venlafaxine, Effexor? In other words, when people have attention deficit hyperactivity disorder, if they're a little bit more in the hyperactive end of things, if they're toward that category, when they try to fall asleep at night, they'll describe not being able to turn off their brain, not be able to calm down those thoughts that are ricocheting around, ping pong ball, shooting around in 3D, right? Their thoughts are everywhere, scattered all over the place. If they have it during the daytime, they certainly have it in the evening and overnight. So sometimes it's a cause of insomnia. So should we try to treat that, or should we allow people to have chronic insomnia from it? Using these medications I mentioned here, which generally we use when people are in recovery because of their low risk. But what about treating a person's ADHD-related insomnia with Adderall or Ritalin? Ritalin comes in a couple of forms. Ritalin is short-acting, or Concerta, which is long-acting, or Vyvanse, which is a long-acting similar to Ritalin medicine. Controversial. I'm not coming up with any answers for it. I'm just posing the question here. Concerta and Vyvanse are very rarely, if ever, seen to be chemically broken up into pieces and used for an acute intoxication. So in other words, Concerta and Vyvanse generally are just once a day long acting and tend not to be broken up so that someone can get a big rush of medicine. But of course, we know that Adderall can, and we know that Ritalin can. So do we treat someone's ADHD when they come in the residential, or do we not treat it? And what do we treat it with? Do we treat it differently in people that are further along in their recovery, or for people that have never had a chemical use disorder? Or do we use it for people that are at low risk? Just topics to ponder. Current standards of care. We use medication replacement for opioid use disorder and alcohol use disorder, benzodiazepine and sedative use disorders, and we use it for tobacco use disorders. Why not for stimulant use disorder? So we use Suboxone, right, buprenorphine, or methadone for opioid use disorders. For alcohol, we tend to substitute in the short term benzodiazepine if someone has a severe intoxication and is at high risk of having severe alcohol withdrawals. We use something close to alcohol. I've been told that alcohol used to be used in certain hospitals as a substitute for people coming out of alcohol withdrawal, but that is not the standard anymore. When people have problems with benzodiazepines or sedatives, we tend to substitute something else, generally longer acting, that's a benzodiazepine, and taper them down more slowly so that it's safer. And for tobacco use disorder, of course, people are familiar with nicotine replacement, either by patch or by lozenge or by gum or by inhalers. There's an oral inhaler, a nasal inhaler. But we don't do that for stimulant use disorder. So we don't take people with methamphetamine or cocaine use disorders and put them on a long-acting stimulant prescription, safer, long-acting without the ups and the downs to try to stabilize them. That's not standard of care. Although there are some people in the addiction world, some very top people in the US that do substitute and will use something like Concerta or Vyvanse or even Adderall or Ritalin, if that's what's available, to help people off their illicit stimulants, for instance. So the DSM-5 describes addiction as a chronic relapsing disorder characterized by compulsive drug seeking, continued use despite harmful consequences and long-lasting changes in the brain. Steroids, performance-enhancing drugs, or testosterone replacement, both. So if someone is on steroids, let's say they're on steroids and they come into a residential facility for an alcohol use disorder or opioid use disorder, maybe they're on testosterone because they're trying to build bigger muscles and get stronger. And that's generally a problem because of the potential side effects of doing so. But sometimes they're on testosterone replacement because their testosterone is low for various medical reasons. Do we stop them or do we allow them to take their testosterone while they're in residential treatment? Should we treat people with hallucinogens? Psilocybin, I can't say psilocybin, I don't know. Magic mushrooms. Should we use that? There's some growing movements in using that and similar items to help with alcohol use disorders, other use disorders, PTSD. Are you as an individual, if you're a treater, or you as an individual as an advisor to someone going through treatment, do you recommend these or not? Just things for you to ponder. Nothing conclusive. Should we allow vaping and tobacco in residential facilities? Both major sources of addiction, both often used by people and have long-term consequences, although the vaping has mixed results. It depends on the context again. But do we allow something like that in a residential treatment facility? Do we let people smoke in between IOP sessions? I've treated patients with chemical use disorders involving ibuprofen. Two come to mind. One is an RN with bad migraines that would meet the criteria for chemical use disorder with ibuprofen. And I've treated someone who literally had to be taken off a plane because she had an acute gastrointestinal bleed. She had acute bleeding in the gut from her ibuprofen use, which was partially an OCD type reaction, but was mainly falling under the criteria of substance use disorder utilizing ibuprofen. So ibuprofen, also known as Motrin, and acetaminophen, also called Tylenol, cross the blood-brain barrier. They get up to the brain, and they both can be lethal. But we tend to allow those when people are in treatment and when people are in recovery. Should we? So a little bit of a palate cleanser before one small short case presentation. And then we'll go to questions and controversies and opinions. By the way, when I went to find a picture of a palate cleanser, excuse me, I I had a difficult time because most of them seemed to be in martini glasses and shot glasses. Didn't think that was appropriate. So I had a tough time finding a picture. This is a short case presentation. 2 different patients. One mine, one someone else's. This is illicitly obtained Suboxone versus early refill request for Suboxone. Person number 1, in the drug court system. So in drug court, has legal problems as well as an opioid use disorder. Confessed to illicitly obtaining 2 days worth of their dose of sublingual Suboxone tablets. Turns out later on, they were found, the reason that they were 2 days short was because of a problem getting to their prescriber, who's not me, getting to the prescriber and getting the medicine filled at the pharmacy. So that was the reason for being 2 days short. So this person chose to do what they've probably been doing for decades, which is they buy things. They buy things from other people. So they bought Suboxone. It would have not shown up on any toxicology test as any different. It would have not been known in any way except this person confessed to it. This person was rewarded with an increased number of community service hours to serve. In other words, they were punished for being non-adherent to treatment. And when I found about this from the person who created the idea in the judge's head to increase up the community service hours, I asked her to reconsider that punishment for someone who very easily could have gotten heroin, fentanyl, kratom, other things instead of getting the Suboxone. But at least they got the Suboxone. It's still illegal to obtain, but I'm trying to help some of the people in the court system to see their role as a little bit more of a therapeutic nature, not so much as a punitive nature. So person number 2 on the very same day emailed me, and this is a person with pre-existing ADHD, obsessive compulsive disorder, alcohol use disorder, and opioid use disorder, very well controlled for years, and is on chronic Suboxone. And in this email, this person confessed to me 5 days before, so not after the fact, 5 days before their scheduled refill date, that they overtook their Suboxone tablets and they were going to run out about 2 days early. And the reason for this is because this person flew back to the East Coast to take care of her elderly mother, and due to time zone difference and changes and airplane and schedules, really just couldn't keep track of her daily dose of when was daytime and when was night for her trip back. And that was the reason. In her case, I called her on the phone, got the information, documented the information, called her pharmacy, explained the situation, and they said they could fill her refill 2 days prior to the scheduled date. In other words, she was not punished for being out 2 days early of her Suboxone as opposed to the first person. In conclusion, what I learned in medical school was the only thing 2 doctors can agree upon is what the third doctor should have done. So in making these decisions about what is acceptable and not acceptable, I guess the whole point of all this is it depends. It's context. And we come with these preconceived notions about certain chemicals, but sometimes they're appropriate and sometimes they're not. And sometimes it changes. Because sometimes it changes, that's why we regularly reevaluate people and the medicines that they're on. So thank you very much. I will turn it back over and we can have a heated discussion about any of this if anyone wants. Thank you.
We do have some interesting comments.
I figured we would.
Yeah. The shortest one is, as a social worker, it depends is my go-to response to many questions. Leimomi said that, and I would agree. I mean, we need to take care of each person's individual needs. That's why artificial intelligence is probably not going to replace the medical profession anytime soon. And so each patient is different. And that all the different medicines you've discussed, great description of all these different medicines for things, points you exactly to why you would have to make it individual for everyone. I really liked how you said, and probably the patient didn't appreciate this, but you said the first patient you talked about had his back pain from work, and he wasn't at work, he was in rehab, so he probably didn't need as many muscle relaxants. You know, most people might just carbon copy everything. And as Dr. Ware says, this topic is a constant source of anxiety and a difficult spot for primary care physicians, as drug interactions, as well as being able to monitor overall health, is one of the primary responsibilities of a primary care physician. It's really hard. There are many drugs on the market, and there are new ones every day. And some are for niche medical problems, which primary care physicians don't take care of every day. So you have to stay up to speed on all these medications on the market. Often it's easier to rely on the expertise of the referral specialist and simply rubber stamp what has been ordered by them. Trying to evaluate treatments outside of one's daily source of usage is time-consuming and often difficult, even if the resources to make an informed decision are readily available. I have found that there are no easy answers. Yes. It is really frustrating, all these new meds. And I hope that pharmacists are able to bill in the future, because wouldn't it be nice if they could go over everybody's medical regimen and make recommendations of things that were covered on their insurance?
It's very difficult. Obviously, there are clinical implications too, right? So the same medicine in someone very similar could be disastrous, and another one, it could be a lifesaver. And we do our best, of course, to try to do no harm and also to help. Right, the algorithm approach just doesn't, the protocol and algorithm approach just doesn't work well. It works some of the time, and it's certainly easier for someone to just rely on that. But it just takes an individual, to take stock of the situation and to make a judgment call. And a lot of that comes with experience and, of course, a lot of up-to-date studying. But as you know, it's not perfect. Sometimes we make the wrong decision and drive people into very disastrous consequences. But
well, even choosing and prescribing a antidepressant. I mean, we don't know, maybe with the DNA tests, we will know which ones people react better to, or rather which ones they process faster. But some of these antidepressants can have horrible side effects in people, and they feel suicidal or anxious. And then some of them will put them to sleep all day. We don't know.
well, someone, a PA from the ER yesterday was talking with me and briefly mentioned naltrexone, which is an opiate blocker, but we also use for alcohol use disorder sometimes too. And he guessed correctly that wouldn't that mean that you also take people's pleasure dopamine rushes away from other things as well? And the answer is yes. It's just not often talked about, that when some people are on medicines that help to reduce dopamine surges from certain things, it will also necessarily reduce dopamine surges from other things, such as good meals or a funny movie or sex, or things that we generally find to be more healthy than using chemical drugs to try to get that dopamine rush. So I see here, there's this comment about primary, it's difficult to find the time, basically, it's difficult to find the time to do this. And so, right, utilizing resources like specialists generally help relieve some of that time, although that's not always the best way to go about a situation. It can be one way. Specialists generally can spend more time, and so we do. Maybe a little too much time, but it's in that communication, I think, that really helps and has helped my patients in the long term that have stayed with me, because we actually communicate often in between when needed. Not so easy to do with a full primary care practice.
No.
Not possible to do well.
No. So Renata says, I think the most important question is, regardless of treatment choice or not to treat, how are we allowing people to maintain their needs? And so this goes back to your first patient. So he needs something for sleep. He needs something to sleep in the recovery home.
Mhm.
Why would we keep it away from him if he needs it and it fits with his medical regimen?
Right. So this was the controversy. So I was covering, so it's not like my job was really to interfere too much. It was really to keep things going and try to do it decently. Their protocols were to try not to give anyone that was potentially problematic, which is excellent, an idea. But as illustrated, it was a Librium taper, gabapentin, Suboxone, and now this medication comes up, and all of a sudden the RN who was there read, oh, this can be abused, this medicine, we shouldn't give it to him. Right or wrong, what happened was, because the insurance company put up such a fight with the barriers of prior authorization, there was a stall before it had to be decided, and the person seemed to be doing pretty well without it, so we kept them off it. But it could have gone the other way. Could have had a severe sleep apnea attack overnight and either died, or more likely would have necessarily felt and looked really badly the next day, maybe to the point of having to have them assessed in the ER. Didn't happen, but could have very well happened.
So Renata has a couple other questions, but she says, I've been out of direct patient care for what I will say is both a short and long time in my mind. I will tell you, looking back at how I did and will approach patient care going forward after much careful thought processes over my time off will be markedly different.
Okay, I mean, we've all been burned too.
Yeah. So she asked, because another question you asked us, thought-provoking question, was whether it's better to be on medicine or not. And Renata asks, are there people with a chemical use disorder that have been treated without any meds? And if so, what are the brain change differences versus treatment with meds?
I'll answer that slightly different than the question is asking. In certain chemical use disorders, such as opioid use disorder, the chance of someone overdosing and relapsing is much, 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 much less if they're on a medication treatment. So medication treatment in general for opioid use disorder is very, very, very much preferred because of the consequences of not giving a medication treatment. Doesn't exactly matter which medication, that's more intricate, but giving some type of medication is much more superior than not when it comes to opioids. That's not the same. That science does not translate over when it comes to stimulants like methamphetamines and cocaine. And in the middle of that is alcohol. Tobacco is more toward the range of, toward the giving the medicine, closer to the statistics with opioid use disorder.
And of
So
course,
which is superior, which is inferior? One, it depends. Two, overall, giving the medicines when it comes to certain substances like opioids and nicotine, tobacco, and closer to that, it would be alcohol. But that's superior than the abstinence approach overall because of relapse rates and overdoses and deaths.
so AA would say it works if you work it. And it does work for many, many people. But then when medications became available, it became a contentious issue. And people would say, well, you have to do it with abstinence, or you don't do it with abstinence, but you can't have both. But I find that acceptance of individual needs is really appreciated. If somebody goes to AA and they're on Suboxone, I think that's great. I mean, they're abstaining from using other addictive drugs. But some people are very purist. I hope.
Well,
calm
that's older information that people have hung on to, of that if you're taking a medicine to help control your use disorder, your chemical use disorder, then you are not, quote unquote, sober. So I think maybe really we should reinvent the terms as being clean or dirty urines, or sober, or
abstinence.
relapse or abstinence. I think those terms maybe aren't helpful anymore, because if my cholesterol is high and I change my diet and exercise and my cholesterol normalizes, that's great. But until that time that it does, I don't think there's any provider that would say, don't go on one of those cholesterol medicines, because that's just going to enable you to not change your diet and exercise and make these non-medication changes. I don't think anyone would leave anyone at risk of a problem like a heart attack or a stroke. I think that same model applies when it comes to addiction. Can't leave people at high risk of something really bad happening to them just so they can say they're not on anything. I say that's.
Yeah, it used to be that if you had your tooth pulled and you were in AA, you couldn't take a narcotic because then you'd have to start over at day one. I think they've softened that. But yeah,
I hope so. There was another person at that facility that had some sort of procedure done. I think it might have been a tooth issue. And the dental surgeon wanted to prescribe 3 days of hydrocodone. And they called me to see what I thought. And I asked if they could keep it secure, and they could. And the people there said, this person's in a lot of pain. We could really tell. And I said it was okay. But there were other places that would have said, no, you can't stay here, for instance, if you're going to be on that.
right.
So,
Well, I know on Maui, they used to take babies away from moms who were on Suboxone when they were born because they were on a substance, but they were in a recovery program and they were prescribed it. You know, it was just, it didn't make any sense. They're doing what's good for them.
well, I guess the in summary is things change, what we know changes and progresses, and you have to keep up with what the outcome-based treatment success rates are. And then how do you measure success? That's a whole other topic. What is success? But if you hold on to the views that you had in the early 80s about addiction, then you'd miss the whole neurochemical biology science that we know that helps us understand what is happening in addiction.
True. So I've been monopolizing the conversation, and then there's a little chat conversation going on about prior auth. which I won't get into because, ooh, that'd be me on my soapbox. But what other questions do folks have?
Well, I hope I got everyone thinking a little bit. That was really just thinking about what they know to be true and what they know not to be true, and kind of stirring that up a little bit.
Leimomi says, I think being aware of internal biases and social stigma is important. Yes, and actually you touched on this because you said changing our terminology from dirty and clean to, I can't remember what you said, but in recovery.
Well, like I had a urine test done with someone today who I know eats a lot of poppy seeds. And I really have no suspicion that it's anything but poppy seeds. But every once in a while, when we perform a toxicology test, it comes up. And her husband, who's also in recovery, said, you know, I told her not to eat that stuff last night in a couple of days because it's going to show up on the test. And he didn't eat it, and his came back negative for opiates, and ours came positive for opiates. And she looked really down and disappointed. And so dirty, clean, failed, passed. We can't, it just, this is what the test showed, and this is what the test didn't show. And we put it into context. She said, I'll come back in 3 days and do another one. I really just love this mixed spice stuff from Whole Foods. And so, you know, you have to find another one because it's just complicating your recovery. I can explain this and we can do it again, but just try to find some other way to flavor your vegetables. It just makes it easier. And they laughed about it, but she felt really badly about it first. And we know that when people feel badly enough, they do something about it.
Right, they'll use. So
If they're that close, right? If they're that susceptible, they'll use so they don't feel badly. That's not the point.
So Dr. Cohn asks, what are we doing about addressing the underlying causes? So that would be a topic for another day.
That's yes, that's a topic. I just was going through medications. I know medications are not the answer for everything.
I think prevention resources would be, there's a lot in Hawaii and they're all over the place, but they're not cataloged or anything. But anyway.
I think we're almost finished. I am going to be doing, if this works out with what I'm trying to put together, I'll be giving more educational talks to basically whoever wants them. I'm just trying to put it together in a more formal way. Just stay tuned. You may hear from me and ask if anyone wants to give me an invitation to talk about basically any topic in addiction that you can think of.
Wonderful. Well, this was very helpful. Next week, we have a community resource speaker. She is Castle's head chaplain, and she's going to talk about what hospital chaplains can do to help folks, to help us with patients, to help patients. So Sarah Colon from Castle is going to talk next week. So if you check out the chat, the thank yous are coming in.
I'm thanking back. Thank you for having me.
And Dr. Ware says, this talk highlights the importance of something I just lost, knowing your referral physicians. Yes, absolutely. All right, well, thank you. And we will see everybody next week.
Thank you, everybody.
Bye-bye.
Thank you.